Hello, and welcome to this webinar on how American drinking habits have changed during the COVID-19 pandemic. My name is Greg Bloss. I'm a program officer at the National Institute on Alcohol Abuse and Alcoholism, which is part of the National Institutes of Health. I'm here because NIAAA commissioned this study, and I've served as the project officer for the project. As many of you know, early in the COVID-19 pandemic, Carolina Barbosa and her colleagues at RTI International conducted a survey to assess changes of alcohol consumption during the first 2 months of the pandemic. The quarantines and social isolation, stress, economic disruptions, changes in alcohol policies, fear, loss of loved ones, changes to daily life, all these led many of us to expect that alcohol consumption and its effects on public health might be significantly affected as well. And indeed, that first survey did find significant increases in alcohol consumption among many respondents. NIAAA has been keenly interested in understanding how alcohol consumption and related behaviors have continued or changed over the ensuing months. Therefore, we contracted with RTI and Carolina to resurvey the original respondents to understand how drinking has been affected over the longer course of the pandemic. When the results of the new survey came in, it became apparent that the task of describing changes in alcohol consumption over the course of the pandemic was actually much more nuanced and challenging than it first appeared. Carolina and her colleagues confronted a multitude of challenges for how to analyze and how to present the rich data that span changes in multiple measures of consumption over multiple time points among respondents with diverse characteristics. Today's presentation provides an in-depth look at these changes and how they vary across groups and over time. And with that, I'll hand it over to Carolina.
Thank you so much for the introduction to the webinar, Greg, and hello, everyone. I'm delighted to be here today, 1 year after our previous webinar, and what a year it's been. I'm going to talk about the results of 2 surveys that we conducted to assess if, how, and for whom alcohol consumption changed during the last year of the COVID-19 pandemic. And the research team is here. Bill and I are going to take you through the study, and then Kate will moderate the discussion. As Greg mentioned, we can see the acknowledgement slide. The first wave of the survey was funded by our institution, RTI International, and the second wave was funded by a contract with NIAAA. I'm going to start with a short background on alcohol consumption and related harms. About 70% of the US population of legal drinking age, so 21 and older, consumed alcohol in 2019. More than half drank alcohol in the past months. And a little over 1/4 reported binge drinking in the past months. The trends in consumption have shown an increase in the prevalence of alcohol use, with higher increases in binge drinking, particularly for women. Also, about 6% of the population meet a criteria for an alcohol use disorder in this country. And we have a big problem that less than 10% of these people get any treatment. We all know that drinking too much is not good, but many people are unaware of the degree to which excessive drinking can damage our health. Next slide, please. Alcohol use is causally linked to more than 200 acute and chronic health conditions. It contributed to an increase of 47% in the number of emergency department visits in the United States, especially among females. And there's an estimated 95,000 people dying from alcohol-related causes annually, making alcohol the 3rd leading preventable cause of death in the United States. And finally, the social costs. The social costs of excessive alcohol consumption are tremendous, about $250 billion in 2010. And these costs come from losses in workplace productivity, healthcare expenses, criminal justice expenses, traffic accidents, property damage. 3/4 of the total cost of alcohol misuse is related to binge drinking. Now, what do we know about alcohol consumption in the midst of the current pandemic? Let's first look at sales data. Next slide, please. One more. Most of you are probably aware of media reports in the early phases of the pandemic, reporting an increase on off-premise alcohol beverage sales. You probably know this, but let me clarify the distinction between off-premises and on-premises. Off-premises are the places where alcohol is meant to be consumed off-site, for example, liquor stores, groceries, and drugstores, whereas on-premises are places where alcohol can be consumed inside, like restaurants and bars. But the spike that we saw early on in the pandemic for off-premises has been uneven, and we also need to account for on-premises sales and the fact that most were closed in the early phases of the pandemic, and after they were operating, and several are still operating under several restrictions. Next slide. We see the percentage changes in monthly per capita sales of spirits, wine, and beer in this graph in 2020 compared to the prior 3-year average for 10 states. And this is for on and off-premise sales combined, excluding online sales. If you look at the dark line for the 3 drink types, we see that there was an increase of almost 6% in March, very large increases in July and September, and a decrease of 3% in November. However, even though there is a correlation between sales and consumption, changes in alcohol sales do not translate to the same changes in alcohol consumption. And they also do not tell us about changes in the way people drink. Can some people be drinking more and in more dangerous patterns? So now let's turn to alcohol consumption data. Right after stay-at-home orders were put in place, there was an explosion of messages across the media. Next slide, please. Stating increases in alcohol consumption. And we now have growing published evidence on the changes in alcohol use in the early phase of the pandemic in the United States. You can see this in the next slide. This includes the results of the first wave of our study, which we presented in a webinar 1 year ago. However, most studies to date on alcohol consumption during the pandemic are cross-sectional or rely on one data point collected during the pandemic, which means that those studies did not follow individuals' consumption throughout the pandemic. So longitudinal data collected during the COVID-19 pandemic are crucial to understand lasting changes in alcohol consumption during these unprecedented times. And this takes us to our survey. I'm going to take you through the survey now. The survey was a web-based survey using a standing panel of more than 55,000 adults. And this is a panel recruited through a method that produces nationally representative estimates for the United States. In wave 2, we resurveyed the same individuals who responded to the previous survey in wave 1. The first wave of the survey was conducted in the second week of May, and the second wave in the last 2 weeks of December and first 2 weeks of January. Now let's take a look at the survey respondents. Almost 1,000 people were surveyed in the first wave. Next slide, please. 80% were resurveyed in wave 2. For analysis, we're going to focus on the 557 who reported drinking at some point throughout the 2 waves. About 55% were past month drinkers at the different time points, and this is consistent with the proportion of past month drinkers found in the 2019 National Survey on Drug Use and Health. The demographic characteristics of our analysis sample are on the right side. 51% of the respondents were female. We have data on respondents 18 years old and older, but for analysis today, we're focusing on those of legal drinking age, so 21 and older. And the sample was equally distributed between our 4 age groups, and race and ethnicity were categorized into white non-Hispanic, Black non-Hispanic, other non-Hispanic, and Hispanic. Now let's look at the survey measures. This table summarizes the measures included in the surveys. In red, we have measures collected in wave 1, and in blue, measures collected in wave 2. The wave 1 survey collected information on alcohol consumption for February 2020, so right before pandemic-related restrictions were put in place in March, and then also collects alcohol consumption for April, 1 month after the restrictions. The Wave 1 survey also collected information on depression and anxiety, history of alcohol-related problems, including receiving advice on reducing drinking and participating in treatment, and employment status. Wave 2 included all Wave 1 questions, but with alcohol consumption relating to July and November of 2020, and additional questions related to alcohol. For example, types of alcohol consumed, places of consumption, motives for drinking from the Drinking Motives questionnaire. It also collected information on income changes since the beginning of the pandemic, other substance use, pregnancy status, experience with COVID-19. So a lot of these measures were collected in Wave 2. And as a standing panel, we also had access to extra information on several other variables, including demographics. For alcohol consumption questions, the surveys first defined the standard drink, and then we asked quantity, frequency, and max quantity and frequency and binge drinking questions. And this allowed us to compute our three main outcome measures. The first measure is average drinks per month. It's a straightforward measure of alcohol consumption. The drinking guidelines, the second measure, refers to consuming no more than 4 drinks per day or 14 per week for men, aged 18 to 64 years, and no more than 3 per day or 7 per week for women and men aged 65 and older. Finally, binge drinking, the third measure, refers to drinking 5 or more drinks in a 2-hour period for men and 4 or more drinks in a 2-hour period for women. In the first wave, we found increases in consumption overall and for all socio-demographic subgroups that we assessed, in particular for females, people with children at home, and Black non-Hispanic people. So using the results for both waves, today we're going to look into how consumption changed over time, if the increases observed in the early phases of the pandemic were sustained over the longer term, if changes over time are larger among certain groups, and the characteristics of those responsible for the largest increases in consumption. In terms of analysis, we constructed a longitudinal data set and conducted analysis for both survey waves. For all descriptives, we applied survey weights. Remember, we're examining alcohol consumption and related behaviors at 4 time points: February, April, July, and November of 2020. Several of our analyses stratified the sample based on drinking outcome to identify relevant patterns. We tested for significant differences between February and all post-pandemic months. And we also use regression models to assess whether changes in alcohol consumption measures varied between complementary subgroups. Now I'm going to start with the results. Again, we're combining data from waves 1 and 2 and looking at outcomes for 4 time points: February, April, July, and November. And our analyses are focusing on the 557 respondents who reported drinking in at least one of the 4 time points. I'm going to begin with the trajectory for our 3 main outcomes over time. Here, we see our first outcome, drinks per month. Comparing to February, average consumption was between 36 and 39% higher in April, July, and November. And the differences between these months and February were all statistically significant. For example, average drinks per month in November was about 23 drinks per month, whereas in February, it was 16.6 drinks per month. So the overall trajectory is characterized by a sustained increase in alcohol consumption. For our second outcome, percent exceeding drinking guidelines, we see an increase from February to April that is sustained in July and November. Exceeding drinking guidelines increased by about 27% in April and stayed at elevated levels afterwards. And let's look at percent binge drinking, our third outcome. Previous slide, yes. We found that in comparison to February, binge drinking among respondents increased by 26% in April, 30% in November. And this was statistically significant. Now, Bill will get into the details of drinking relative to February, changes in drinking preferences, and finally, how our main outcomes vary over time when we stratify by key characteristics. Let's turn it to Bill.
Thank you, Carolina, and good afternoon, everyone. For the next few slides, we're going to examine changes in alcohol consumption relative to February, or right before the pandemic started. Each column on this chart represents one of the 3 pandemic months, April, July, or November, and the colors in the bars represent the proportion of the sample that increased their drinking relative to February in red, drank the same amount in February in a pandemic month in green, or decreased their drinking in blue. The paths between columns show the transition between the 3 categories from month to month. In April, about 39% of respondents drank more than they had in February. Another 39% drank the same amount in the 2 months, and 22% drank less in April than in February. The proportion of respondents drinking more than in February increased over time from 39% in April to 49% in July and to 54% in November. And the increase in drinking among respondents who drank more in November than in February was substantial. Average consumption in this group more than doubled from 15 drinks per month in February to 33 in November. Next slide, please. On this slide and the next, we're going to take a deeper look into those who drank more in any pandemic month relative to February. In other words, they drank more in at least one of April, July, or November than they had in February. About 400 respondents met this criterion. In the figure on this slide, which is called a tree map, respondents are stratified into groups depending on the pandemic month or months in which they drank more than they had in February. For example, respondents who drank more in all 3 recorded pandemic months are in the AJN segment at the bottom left, which stands for April, July, and November. About a quarter of the respondents who ever drank more after the pandemic started did so in all 3 months. The size of each segment indicates the proportion of the subsample in each group, and the color represents the average increase in drinks relative to February in the month or months they drank more than they had in February. The brightest red color represents the largest increase. I'd like to highlight a few of the groups here. In the middle of the figure, we see that almost 13% consumed more in April than in February, but then reduced their drinking to February levels or lower in July and November. We call this our brief increase group. 5% consumed more in both April and July than they had in February, and we call this our early to mid increase group. We characterize the AJN group that we discussed previously to have exhibited an early and sustained increase in drinking. There were significant differences across these groups in drinking for coping or enhancement motives. For example, 66% of the respondents in the early and sustained increase group, or the AJN group, reported drinking to cope during the study, compared to 46% across the other groups. We see that respondents with early and sustained increases, the AJN segment, represent the largest group, and this group is also responsible for the largest increase in consumption relative to February. This group consumed an average of 26 more drinks, or almost 1 drink per day, in the pandemic months compared to what they had consumed before the pandemic in February. By contrast, respondents who exhibited a brief increase, the A group in the middle of the chart, drank an average of 12 extra drinks in April than in February, and then drank the same or less than they had in February in the latter 2 months. The early to mid increase group, the AJ group, drank about 19 more drinks on average in both April and July than they had in February. Finally, we found that respondents in the AJN group were more likely to have kids in the household, 40%, compared to all other respondents, 26%. Now we're going to take a look at how drinking preferences changed after the onset of the pandemic. Next slide, please. This chart shows what type of alcoholic beverages respondents drank the most each month, conditional on their drinking in a given month. We didn't measure this for April, so we have data representing February, July, and November. We see more respondents drinking wine in cooler months and higher beer and hard seltzer consumption in July. The literature suggests, based on sales data, that demand for beer increases in warmer periods. Thus, it's likely that the differences we observe are due to seasonal preferences rather than pandemic or associated policies. Next, we look at where people drank. On the next, thank you. The categories on this chart are not mutually exclusive. Rather, respondents reported whether they drank in each of the location categories separately. Unsurprisingly, the vast majority of people who drank reported doing so at home. The second bar in each cluster represents the percent of respondents who reported drinking at someone else's home. Interestingly, about the same proportion of respondents reported drinking at someone else's home in February and July. It must be acknowledged that we're not able to seasonally adjust these data. It seems likely that in a typical year without a pandemic, we may expect more social gatherings at individuals' homes that involve drinking in July than in February, due to the summer season in general and the Independence Day holiday specifically. So the fact that we observe similar percentages of respondents reporting drinking at someone else's home might be indicative of an actual decline in drinking elsewhere at someone else's home relative to what might be expected in normal times. Drinking at someone else's home declined from July to November, which may be influenced by the seasonal patterns we just discussed, but may also have been influenced by the second wave of COVID-19 infections experienced around that time. Not surprisingly, drinking in bars and restaurants declined considerably from February to the pandemic period. The third bar in each cluster represents the percent of respondents who reported drinking at a restaurant. 42% reported this in February, compared to 19% and 18% in July and November, respectively. The fourth bar represents drinking in a bar, which declined from 18% in February to 8% in both July and November. These findings suggest that the pandemic and policies designed to mitigate it may have reduced visits to bars and restaurants, and that alcohol consumption in bars and restaurants remained low throughout the fall of 2020, despite the gradual lifting of restrictions in several states, according to data published by NIAAA and its Alcohol Policy Information System. So we've established that across all respondents, drinks per month, drinking in excess of recommended guidelines, and binge drinking all increased. We also saw that the proportion of respondents drinking more than they had right before the pandemic increased over the study period, but that those with an early and sustained increase were responsible for the largest average increase in consumption. Now let's look and see whether changes varied across specific subgroups. On this slide and for the next two, we've used regression models to control for respondent demographics and pre-pandemic socioeconomic status in order to isolate differences between specific characteristics. We'll look at three characteristics here: gender on this slide, then race, ethnicity, and family composition, which we define by whether or not the respondent had a minor child in his or her household. Here we see outcomes plotted separately for females and males. We see that all three outcomes increased after the pandemic for both groups. For drinks per month, the absolute increase was roughly the same for males and females. However, because the average woman drank about half as much as the average man in February, the relative increase in consumption is larger for women than for men. The difference between these groups is most evident in drinking above recommended guidelines, the middle panel. The change in exceeding drinking guidelines from February to April was statistically significantly larger for women than for men, and women actually surpassed men on this measure starting in April. For women, the proportion exceeding guidelines increased by 54% from February to November, compared to 32% for men. Women also significantly increased binge drinking from February to April by 44%. Men increased binge drinking gradually over time, but it was not significantly different in February in any of the post-pandemic months. Next, thank you. Here we stratify the drinking outcomes by race, ethnicity. For legibility purposes, we've highlighted the two groups, white non-Hispanic and black non-Hispanic respondents, with the most dramatic differences. White non-Hispanic respondents exhibited a modest increase on all three outcomes over the study period. In contrast, consumption outcomes for black non-Hispanic respondents increased considerably. Drinks per month increased from 8 in February to 23 in November. The percent exceeding drinking guidelines went from 6% in February to 37% in November. And the percent binge drinking went from 5% in February to 29% in November. The February to November differences are significant for black non-Hispanic respondents on all three outcomes. On the two binary outcomes, exceeding drinking guidelines and binge drinking, black respondents increased by a factor of about 6 from February to November. For both outcomes, the increase for black respondents from February to November was significantly larger than for white respondents. It's important to note that while our focus here is on changes in drinking as they relate to the pandemic, there are several other factors that could explain increases in alcohol consumption during 2020, such as demonstrations against racial injustice and a tense political climate in the lead up to the 2020 election. More work is needed to truly understand the causes of the observed increase in alcohol consumption and risky drinking, especially for key subgroups that may have been differentially impacted by the pandemic, as well as other social forces over the past year. Finally, here we see the three outcomes for respondents with and without children in the household. Alcohol consumption increased for both groups over time, but the change in consumption was significantly larger for respondents with children in the household from February to April and from February to November. Drinks per month for respondents with children in the household increased from 22 to 37 from February to November, with most of the observed increase happening from February to April. Next slide, please. On this slide and for the next three, we look at interactions between the key characteristics we just examined. On this slide and the next, we'll look at race, ethnicity, and gender groups. And then on the following two slides, we'll look at gender and family composition groups. We're looking now at our first outcome, consumption or drinks per month, and not the binary outcomes, exceeding drinking guidelines and binge drinking. In each set of two slides, the first, this slide, shows a stacked area plot in which the y-axis represents cumulative drinks consumed. Color represents race ethnicity groups, and pattern represents gender, with the solid segments at the top representing males and the dotted segments representing females. The width of each segment at each time point represents that group's contribution to total consumption. So segments that widen over time represent groups that consumed more on average. The labels to the left and right represent total drinks for each group in February and November, respectively. Because this plot excludes respondents with missing drinking data in one or more months, the respondents in each group are the same over time. A key message from this plot, which you already know from our main outcome slide, is that total consumption increased mainly from February to April, and that this increase was then sustained through November. 4 groups more than doubled their consumption from February to November, and we'll look more closely at those on the next slide. So to more clearly illuminate drinking patterns across time for each group, here we've plotted average drinks per month for each group separately. You can see that the 4 groups more than doubled their consumption. Black males increased average consumption by a factor of 2.7 from February to November. Males that are neither Black, white, nor Hispanic increased average consumption by a factor of 3.1. Black females increased average consumption by a factor of 2.7, and Hispanic females increased total consumption by a factor of 2.5. While this two-way stratification is a useful way to describe the data, the small sample sizes in the cells must be noted as a limitation. Now we're looking at consumption over time by gender and family composition groups. We define family composition groups by the age of the youngest child in the household. No children, 0 to 5, 6 to 12, and 13 to 17. Although respondents without kids contribute a lot to aggregate consumption, primarily because they make up about 3/4 of our sample, both males and females in this group exhibited relatively small increases over time. As the next slide will make clear, average per person consumption among respondents without kids is relatively low over the study period, especially among men. So as I noted, we see in the top row that among men, average consumption in the no children group is always lower than in any of the groups representing males with children in the household. We see that average consumption is highest among males with older children, but the largest increase in consumption was for females with kids under 5, with a more than 4 times increase in total drinks consumed from February to November. Females with kids aged 6 to 12 also doubled their average consumption from February to November. The last 2 results slides look at the intersection between drinking motives and mental health. To do this, we'll use tree maps like we looked at earlier. The figure on this slide focuses on drinking to cope, represented by a C in the chart. And the figure on the next slide will focus on drinking for enhancement motives, represented by an E. Both slides use MH to represent a score of 3 or more on either the PHQ-2 or the GAD-2, indicative of symptoms of depression or anxiety, respectively. This slide contains 2 tree maps, one for February at the top and one for November at the bottom. The sample is the same across time and comprises 328 respondents who reported drinking in both February and November. This slide conveys 2 important pieces of information. First, changes in the size of the segments from the top, February, to the bottom, November, show how drinking to cope and mental health symptoms changed over time. Second, the color of the segment represents average consumption, low to high from blue to red, among respondents in each group and in February and November, respectively. So you can see that the percent of respondents that both endorsed drinking to cope and had mental health symptoms nearly tripled from 5 to 15%, and that consumption in that group intensified from 39 to 53 drinks on average. So more individuals were drinking to cope and had mental health problems in November than in February, and average consumption among respondents meeting both criteria increased by about 1 extra drink every other day. This slide is configured in the same way as the last, but now we're looking at enhancement motives rather than coping motives. Most respondents who drank in any given month indicated that they drank for enhancement, for example, to achieve a pleasant feeling. As a result, very few respondents had mental health symptoms, but did not endorse enhancement motives, and thus this segment is nearly invisible on the chart. As with coping, the percentage of people who endorsed enhancement motives and had mental health symptoms nearly tripled from 6 to 16.5% between February and November, and average consumption in that group increased from 35 to 49 drinks. Now I'll pass things back to Carolina to conclude our presentation.
Thank you, Bill. So let me try to summarize some of our key results. We have a slide here with the summary numbers. So we just pulled the key numbers that I would like you to think about. We found that there was an increase of 36% on average alcohol consumption between February and April, and that alcohol consumption in November was 39% higher than in February of 2020. The proportion of people exceeding drinking guidelines increased 27% between February and April, and that increase jumped to 39% between February and November. Binge drinking saw an increase of 26% between February and April, with a further increase to 30% between February and November 2020. If we use the US population of 166 million drinkers of legal drinking age, this translates to an increase from February to November of 1 billion more drinks per month. 14.6 million more people exceeding drinking guidelines, and 9 million more people binge drinking. The largest increases in average consumption from February to November were for Black and Hispanic women, Black men, men who selected other than white, Black, and Hispanic for their race ethnicity, and women with children under age 5 in a household. Remember that more women than men were exceeding recommended drinking guidelines between April and November of 2020. And a striking figure, compared with February 2020, the proportion of Black individuals drinking above recommended guidelines increased by about 140% by April, and this jumped to a 500% increase by November. So what are the key takeaways? We see increases in alcohol consumption, including excessive consumption, were sustained from April to November 2020 overall and across several groups. The largest increases in consumption were observed in Black people, people with children, and people with mental health problems who drink to cope. Among women, early increases were sustained over time, with more women than men exceeding recommended drinking guidelines between April and November 2020. And among those with children, the largest increases in consumption occurred among women with young children in the ages of 0 to 5. These findings of differential negative impacts pose real concerns because there's already other evidence of gender and race ethnicity disparities in the impacts of excessive alcohol consumption. And the high increases in drinking above guidelines for women is concerning because women are more susceptible than men to the effects of alcohol-related liver injury. And in the past 2 decades, alcohol consumption and related emergency department visits, hospitalization, and death have increased markedly among women. And there's a concern that the pandemic might exacerbate these troubling trends and also compound existing disparities in the consequences of excessive alcohol consumption on racial and ethnic minorities. So what's next? Our results show the importance of surveillance of alcohol consumption with special attention to marginalized communities. It is also important to monitor alcohol attributable harms during and following the COVID-19 crisis, because understanding these harms can help better prioritizing interventions and improving responses in the future. And it's also important to increase the implementation of strategies to prevent and mitigate the consequences of increased drinking during the pandemic. Policymakers should be prepared to respond to the public health consequences of such a sudden, sustained increase in alcohol consumption, and should also consider lessons learned from the pandemic. For example, relaxing regulations during the pandemic to allow curbside pickup and extending privileges for home delivery might have contributed to increased consumption. And now some of these relaxed regulations are being permanently adopted. Finally, it will be important to continue following our respondents to assess their longer-term drinking patterns. Thank you so much for listening today. Greg Bloss is now going to provide a few concluding remarks, and this will be followed by a Q&A.
Thank you, Carolina, and thanks for the very nice presentation. I appreciate the opportunity to try to summarize what I see as the key takeaways from the study. The main conclusions that I see, one is that overall alcohol consumption has remained at a higher level during the pandemic than it was previously. Another is that certain groups have exhibited much greater increases in consumption or risky consumption behaviors than others. Of specific note, the percentage of Black respondents who exceeded drinking guidelines or who engaged in binge drinking increased by a factor of more than 5, while overall consumption among Black men and Black women nearly tripled, bringing their levels up to a par with those of white respondents. Women with young children at home increased their consumption more than 4-fold, while men with teenagers at home nearly doubled their consumption. Respondents who indicated that they drank as a way to cope with stressors and problems had higher consumption levels and were more likely to engage in risky drinking before the pandemic began. And they not only sustained the initial increases in all categories of drinking, but further increased these behaviors significantly during the period covered by the study. For respondents with depression or anxiety, these increases were especially pronounced. So what can we conclude from these findings? Clearly, the population health risks associated with alcohol consumption are likely to be exacerbated by the changes observed during the pandemic. There's a real concern that these changes could represent a new normal with the potential to lead to significant adverse consequences for public health, both in terms of acute outcomes associated with binge drinking and in terms of chronic health effects. Those of us who work to identify effective strategies for preventing problems that stem from alcohol misuse need to be attuned to the changing epidemiology of alcohol consumption. New approaches may be needed to avoid worsening problems in marginalized communities and adverse consequences within families. I want to note that this survey is not the last word on changes in alcohol consumption associated with the COVID-19 pandemic. We're all hearing of the rising case counts and hospitalizations associated with the Delta variant, the possibility of further restrictions on gatherings, travel, and commerce, even as our fatigue with the ongoing challenges of the pandemic keeps rising. I think that we will need further monitoring of changes in drinking behavior. At least as important, we also need research to understand the underlying factors that are driving these increases in risky drinking and to identify strategies that can mitigate them among those who are most vulnerable. So this survey is a valuable step along that path. I want to end just by thanking Carolina Barbosa, Bill Dowd, Kate Carricker-Jaffe, and Alan Barnoski at RTI for their work on this project. Their initiative in fielding the initial survey and their dedication and focus in bringing the resurvey to fruition provide valuable data for understanding important nuances of the effects of the COVID pandemic. I also want to thank colleagues at NIAAA, especially Dr. Mike Hilton, who helped conceptualize the project and who, along with Drs. Aaron White, Laura Quacco, and Ralph Hingson, provided valuable feedback and insights along the way. And lastly, thanks to Jeremy White and Edwin Osorio for navigating the thickets of government contracting rules to help keep the project on track. And with that, I'll stop and turn it over to Kate, who will moderate the Q&A session.
Great, thanks everybody. Before we get started with the substantive questions, I just wanted to give a chance for one clarification. Bill, you mentioned that you could give some clarification on the line graphs comparing groups and the changes over time.
Certainly. So we no longer have the slides up in front of us, and you can take a look when we send the slides around. But the 3 line graphs that looked at differences by demographic characteristics, the y-axis did represent levels. So, for example, there was a question about whether Black non-Hispanic respondents had a higher rate of drinking in excess of recommended guidelines in November than white non-Hispanic respondents. The answer is yes. My discussion around that slide was primarily focused on whether or not the change was significant, since that was sort of our research question from before to after the pandemic, but the charts themselves did present levels in those times. So you can interpret the data that way.
Great, thanks, Bill. So we also had a couple of questions come in about seasonality and just changes typically in a given year over a month to month in drinking. Carolina, did you want to address seasonality in a little bit more detail than Bill did? He discussed a little bit about beer consumption and beer sales, but if there's more details you want to give on that?
Yes, I'll try. The reality is that we need to acknowledge it as a limitation. We did not adjust for seasonal variation, but it's tricky to do so given the current circumstances, where it's hard to judge how seasonal variation might impact consumption during the pandemic, because most seasonal variation where alcohol consumption increases, for example, in July and during Christmas, so in holidays, and also the Cinco de Mayo. So those big holidays usually are associated with large increases in consumption, but the reality is that these events were lived in a very different context last year. And I think it will be also important to note that there are, that I know, 2 published studies, a little bit old, that did show mostly changes in self-reported alcohol consumption. I know that I'm talking about self-reported because self-reported is different from sales data. And those 2 studies showed that there are no changes, there's no big change in self-reported consumption between February and April. And it's between February and April that we see the largest jump in all our measures. So from right before the pandemic to after restrictions were put in place. So usually both February and April are months where self-reported consumption is low. If we look at sales data, and as I mentioned, there's a correlation between sales and consumption data, but it's not exactly the same. We do see also large increases in months to months off-premise sales from February to April. And the same when we look at combined on and off premises. I think it's also very interesting to see what Bill pointed in terms of place of consumption and how it didn't actually change from earlier months to summer months, where usually you would think it would change. So the same percentage of people were drinking at home. Bill, do you want to repeat that part?
So the finding was that the proportion of respondents who drank at someone else's home, so we're thinking about social gatherings and picnics and family events and that sort of thing, was the same from February to July. I don't know of any studies that look specifically at family gatherings and alcohol consumption at them, but my expectation is that in a usual month, you'd expect more of that to happen in July than February. So it speaks to maybe the pandemic had an effect. We all know that. We all remember that maybe we weren't getting together with family as much and celebrating things that we might have done in a typical year. So.
Great, thanks everybody. And we have put up a couple of poll questions. I think there's still a second one up on your screen. So if you have a second to let us know your answers to the poll question, we'd appreciate that. So we do have some questions about additional details that we aren't able to present today. And I just wanted to mention for everyone that we are planning a publication and a full report on this. And so we will hopefully be getting those results out soon. We had a couple of questions that I think we could group together about implications in relation to policy changes that you mentioned a couple of times, and drinking locations is a good segue into that. People are wondering about implications of the findings for debates over changes in alcohol availability that occurred during the pandemic, and what will happen if some of those remain permanent, for example.
I'll start with that. That's something that we are very interested in studying. It's for a researcher, this is great. It's like an actual experiment. We have all the data, and we know that APIS is collecting all the changes in policies that happened, and all the policies since the beginning of the pandemic, and the policies that were affected were actual accessibility policies. So changes in curbside pickup, alcohol deliveries from both on and off premises. So we do have the data to then link to APIS and do some policy analysis. We have not done that yet, but that's certainly an interest that we have and that we plan on doing. I'm sure Kate and Bill might have something to say, because we've been discussing this research idea for a while.
Bill, do you have additional thoughts to add?
You covered it, Carolina. Yeah, we're looking forward to getting into that. Obviously, really important issue. So keep your watch the space for more on that.
Right.
I think another related question that we would like to do if we have the opportunity is to look more in depth at the long-term changes in terms of alcohol use disorder. And there's been some couple questions in the Q&A about that as well, in terms of analyses that we might be able to do with these data related to alcohol-related problems. Carolina or Bill, do you want to share more details about what we are and aren't able to do with the measures that we have at this point?
So due to space constraints, we did not include questions that would allow us to formally diagnose someone with AUD. So that, the DSM-5 questions are a little bit lengthy. We did include questions on previous treatment and indicators for previous alcohol problems. The sample size was small to really do many more analyses with that. But it will be interesting, and we can think that the implications of, with the increases in consumption, and a lot of people that started, particularly in the beginning of the pandemic, was mainly drinking at home, and if this keeps being used, increased consumption, alcohol consumption keeps being used as a mechanism to cope, we can think of longer term changes and probably an increase in alcohol use disorder that will come from the pandemic.
And some of the other questions that have come up are related to other types of harms, not only to the drinker, but to a drinker's family, such as harms to children, and things like domestic violence. And unfortunately, we didn't have detailed questions on those issues in our data, but these are really important questions, especially as, for example, kids are out of schools, and so that's a key avenue into social services. And so that wasn't available while kids are at home. So definitely there's room for more long-term work to look at the implications of these changes in drinking over time. We also had a question about how treatment and prevention might respond to these increases. Did anyone want to speak on that, about ideas for moving forward to mitigate harms?
Well, it's reaching more people, trying to work more on the prevention side, particularly, I think what we learn from here is hopefully not many more pandemics will happen, and we're still on this one. It's not like we're done with COVID-19. We're not, but we can learn that prevention and increasing messaging on what is excessive drinking, because many people still do not know the consequences of excessive drinking or what exactly is excessive drinking. So I think the prevention side should increase that message, and also I think telemedicine will be very important to increase reach, to try to mitigate the consequences of increased consumption.
Yeah, and if I could add to that, one of the key findings from the first wave, and that we've actually included a little bit more on that in the report on this study that'll be coming out shortly, is that a lot of the increase that we observed from February to April was concentrated among people who were not drinking in excess of recommended guidelines in February. So it suggests that maybe there's a need for primary care folks to screen and make sure that they're aware of whether their patients may have developed risky drinking habits during the pandemic that maybe they weren't before. So it makes the case for primary care and those types of interventions like SBI and those sorts of things that we know are effective, that might be a good response to this issue.
The questions are coming in fast and furious. I'm trying to read the most recent ones. So we did have questions about service utilization. And we talked about telemedicine just now briefly. We didn't assess in detail mental health service utilization or treatment utilization during the pandemic. And one question was whether there are other similar data available that people have been looking at increase into treatment during the pandemic. I know there was some data showing a decrease in treatment admissions in California, for example. But are there other data sources that would help us understand sort of how people might or might not be getting linked into care during this period?
Treatment episode data set comes to mind, TEDS data. I haven't looked at it personally, but that may be an answer to look into that. I don't know that there's, high frequency data in those. I'm not sure if you can get below a year, but that might be something we could look at. That's a great question.
Great. We had another question. We had a couple questions on geographic differences and social determinants of health, and thinking about what implications might be of things like isolation and restriction on drinking, as well as just geographic differences between openings and closings across states in response to the pandemic. Are there any things related to that we might be able to address in this data that we haven't been able to do so far?
Those are some of the, I think those are the analyses that we also plan on doing, actually including contextual COVID data in our regressions, which is publicly available. And our data does have the location where respondents are from to the zip code level. So we can definitely include that.
And a couple of people have asked whether the data would be available for other researchers to use.
We still need to talk about that.
I think in the final 5 minutes, it might be an interesting topic to end thinking about what to do a little bit more on prevention and intervention side, but also how to continue to raise the issue and the profile of alcohol as an important public health problem. Right now, we've seen a lot of increases in opioid-involved fatalities and things that take a lot of public health response for good reason. But thinking about what to do with alcohol in that mix might be increasingly important if drinking is going up, as well as some of the drivers of other drug use. Do you have any thoughts on that, Carolina or Bill, in terms of interactions or differences with opioids or similarities across these different issues?
Well, we also know that many of the opioid overdose, I think one third of opioid overdose have alcohol involved. I mean, certainly opioids, and particularly during COVID, the number of deaths has increased dramatically. But alcohol is also important. I don't think we should be competing which one is more important depending on our research field. I think both are very important. Maybe we can think about equally funding research on both sides and combine. I think that's more of the issue.
There are some other surveys that look at general population surveys, like the NISDA, the National Survey on Drug Use and Health, that look at changes in consumption of alcohol and other specific drugs during the pandemic period. And so we'll all look for those findings to come out as well, in terms of how people may or may not be using things together or substituting, complementing drugs, with some combinations, as we know, being much more risky than others, as you mentioned, Carolina. Again, to wrap up, we did state at the beginning that we will share a link to the webinar and some handouts from the presentation. So if you want to refer to this information moving forward, or if you want to share it with colleagues or policymakers or others who might be interested, you should receive an email in response to the same email address that you used to register for the webinar. Do we have any final comments as we wrap up our hour together? Carolina, Bill, Greg?
Well, thank you so much, well, to NIAAA for making the second wave of the survey. You know, otherwise it wouldn't have happened. So thank you. And the great research team, and also Shane that put all the technicalities of the webinar all together. Thank you, Shane. And thank you to our audience, and do not hesitate to contact us if you have any questions or suggestions. We would love to continue doing our work.
We will present probably additional details in the subsequent publication that we weren't able to go into today. So there are a couple questions about like socioeconomic differences and things like that that we hope to address in the publication as well.
Yes, the income, the age groups, so that we did all those analyses, just couldn't present it all today. But we have it. We'll present on that, publish on that, hopefully.
Great. Well, thanks everybody for coming, and have a good rest of your day.